Hello everyone, my name is Michelle McKinnell, and I will be presenting Chapter 10, The Endocrine System, from Applied Pathophysiology for the Advanced Practice Nurse, 2nd edition by Douglas and Story. So the first question to ask ourselves is, what exactly is the endocrine system? Well, the endocrine system is a grouping of glands located throughout the body that are responsible for the secretion of hormones and chemical transmitters directly from endocrine cells into the bloodstream. These secreted hormones affect things like growth and development, metabolism, sexual function, reproduction, and even mood stability. They accomplish this by binding to receptor sites on the surface or within target cells. And it also takes very little hormone to make a significant change at the cellular level, so any fluctuation, even minor, can have pretty significant effects on the organism as a whole. Now, there are two different types of hormones. We have our tropic hormones and our non-tropic hormones. Tropic hormones are going to be our endocrine hormones. These are the ones we're talking about today that target distant glands and distant cells throughout the body. Non-tropic hormones are going to be non-endocrine hormones, and those are ones that either act on themselves, autocrine hormones, or on neighboring cells or nearby cells, and those are called paracrine hormones. So back to the endocrine hormones. We have two different types. We have our fat-soluble hormones and our water-soluble hormones. So fat-soluble hormones are bound proteins. These must be unbound before affecting a target cell. These are going to be things like steroids and fatty acid derivatives. Water-soluble hormones are in their free form, and those can directly bind to the target cell. These are going to be things like proteins, polypeptides, and amines. Now, there are different kinds of regulation for these hormones in order to keep them in check, as you will. Two different mechanisms. We have our negative feedback mechanism, which is going to be our most common, and our positive feedback mechanism, which is going to be our least common. So in a negative feedback mechanism, the hormone inhibits its own production. The levels rise in the bloodstream, which means less hormones are produced. So as the level declines in the bloodstream, the production increases to increase the amount of hormone. Now, this also can lead to something called downregulation, which is where high hormone levels decrease the number of cell receptors or the cell's affinity to the hormone. So if there are too many hormones in the bloodstream, the body can actually help stop absorbing some of it. The other way that a negative feedback mechanism works is if you have too much hormone in the bloodstream and then you have too little, your production increases. Another thing that can happen is called upregulation, and that's where low hormone levels cause an increase in the number of cell receptors. So the body can attempt to, try to use up every little bit of hormone that it can if it's in need. The other kind of mechanism is our positive feedback mechanism, and that is when hormone levels are already high, and then they become even higher. This will cause the production of that hormone to increase. And when the levels drop, production stops altogether. This is a pretty rare feedback mechanism. This one happens a lot when oxytocin is released during childbirth. That is one way that the body deals with that. And so going to the glands of the endocrine system, we have our hypothalamus, which is kind of our, computer center of all this. It's located in the brain. Here's your hypothalamus here, and it sits directly above your anterior and posterior pituitary. Now, your hypothalamus secretes some different hormones that in turn will target cells on the anterior pituitary. These are secreted directly through the bloodstream to cause this effect, whereas, as you'll see in a moment, in the posterior pituitary, it receives signals from the hypothalamus with neuroglial cells. So in the hypothalamus, we have our corticotropin releasing hormone. This is going to directly affect the corticotrope cells in the anterior pituitary, and that in turn is going to release the adrenocorticotropic hormone. And this adrenocorticotropic hormone targets, as you might have guessed, the adrenal glands of the kidneys. Now, another hormone that the hypothalamus releases is your thyroid-stimulating hormone and somatostatin. Now, these are going to target thyrotropes in the anterior pituitary, and that will in turn release thyroid-stimulating hormone. This hormone is going to target your thyroid gland to get it to produce its hormones. The next hormone that the hypothalamus releases is the gonadotropin-releasing hormone. This one is going to directly affect the gonadotropes within the anterior pituitary. Those in turn will secrete follicle-stimulating hormone and luteinizing hormone, and these are going to affect your testes and your ovaries. Now, the next hormone to be secreted by the hypothalamus is going to be your growth hormone releasing hormone, as well as somatostatin. That's going to target your somatotropes within the anterior pituitary, and that is going to release in turn your growth hormone. Growth hormone generally starts working on the liver. The final hormone that your hypothalamus is going to release is the thyrotropin releasing hormone and your vasoactive intestinal peptide. These two hormones are going to target lactotrophs within the anterior pituitary, which is going to release prolactin, and prolactin is going to mainly involve the mammary tissue. Now, your posterior pituitary gland, which again is this one here, that is going to, as we can kind of come back up to our picture up here, going to receive signals from the hypothalamus by what's called neuroglial cells. Now, these neuroglial cells actually release a chemical transmitter that then will target cells within the posterior pituitary and cause them to release their hormones. So coming back to our diagram down here, the posterior pituitary is going to produce two different hormones after it gets the signal from those neuroglial cells. Oxytocin is going to help with contraction in the uterus during labor, as well as targets the mammary gland tissue. The other hormone that is produced in the posterior pituitary is going to be your antidiuretic hormone. This antidiuretic hormone is actually going to come all the way around to work on the kidneys. So as you can see, the hypothalamus releases hormones that are either excitatory, which is displayed as a plus sign, or inhibitory, which is displayed as a negative sign, to target the cells in the anterior pituitary, which will then release hormones to the target glands, helping them release their own hormones. And then the posterior pituitary gets its signals from the hypothalamus with the neuroglial cells producing oxytocin and antidiuretic hormone, and those are going to again target the target cells. So as we kind of go to the specific glands, we'll start with the adrenals. These are located on top of the kidneys here. They have what's called a cortex and a medulla. As you can see, the medulla is this like middle bit, and the cortex is going to be the outside. The cortex has three zones: the zona glomerulosa, the zona fasciculata, and the zona reticularis. As you can kind of see down here, the reticularis is on the innermost side, fasciculata in the middle, and glomerulosa on the outermost edge. Each one of these zones produces hormones called corticoids. The zona glomerulosa is going to produce your mineralocorticoids, which often is usually aldosterone. The zona fasciculata is going to produce glucocorticoids, the main one being cortisol. And then your gonadicocorticoids are going to produce a couple of other hormones that are responsible for effects on reproduction. The medulla is going to produce two things, epinephrine and norepinephrine, both of which are pretty important to flight or fight of the body. And the last thing, there is something inside the kidneys that we're going to talk about later. In the proximal tubule of the nephron is where calcitriol is produced. That is also known as vitamin D3, and we will talk about that here shortly with the thyroid gland. So in the thyroid, that is located in the anterior portion of the neck. The parathyroid glands are kind of these four little ones here, and those are just located on top of the thyroid. Those have their own kind of function. The thyroid gland is going to produce T4 and T3, as well as calcitonin. Calcitonin is responsible for lowering the calcium level in the bloodstream, which can be pretty important if calcium levels are running really high. Your parathyroid hormone, which is going to come from your parathyroid glands, those are responsible for increasing your calcium levels and decreasing your phosphorus levels, and that helps in the regulation of calcium. Now, if for some reason the body needs to raise its phosphorus levels, parathyroid hormone can, with the aid of vitamin D3 and calcitriol from the proximal tubules of the nephron, can in turn help increase your phosphorus level. So that's kind of how the thyroid works with the kidney. The next organ that we're going to be talking about is the pancreas. And the pancreas has these little islands inside called islet of Langerhans. These little islets are very numerous. There's millions of them in your pancreas. And each islet has 5 different kinds of cells in it. And each cell has a certain percentage of how many there are in this islet. There are 5 different types of cells. You have your alpha cells, your beta, delta, pancreatic, polypeptide, and epsilon cells. Now your alpha cells are going to secrete glucagon, your beta cells are going to secrete insulin and amylin, and your delta cells are going to secrete somatostatin and gastrin. Now your pancreatic polypeptide cells are going to produce pancreatic polypeptide, and your epsilon cells are going to produce ghrelin. All of these have a function within the body in order to maintain glucose levels, as well as assisting to provide feelings of being hungry or feelings of being full in order to help with some of the regulation of glucose. Now, there are a few ways that the body synthesizes glucose and kind of adjusts things, as you will, if it is insufficient in certain molecules or hormones. It will kind of do these different processes to help synthesize glucose, to help either make more glucose or take some of the extra glucose and try to break it down. A lot of this happens in the liver, back up here. And so glucose can be synthesized in 4 ways. We have the glycogenolysis, which is where we convert glycogen to glucose. We have glycogenesis, which is going to convert glucose to glycogen. Gluconeogenesis, which is going to take an acid called pyruvate and make glucose. Or glycolysis, which is going to in turn take glucose and turn it into pyruvate. And so as you can see, the body does different things to help regulate glucose if it's sufficient, or break it down if there's too much. Now, disorders of the endocrine system, these are going to be different conditions and diseases that are caused by either too little or too much of some of the hormones we talked about. So in your anterior pituitary, we talked about the 5 hormones that are produced. Your growth hormone, your follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, your adrenocorticotropic hormone, and prolactin. So with the growth hormone, if we have too little, we get what's called dwarfism. Too much, acromegaly and giantism. Follicle stimulating hormone, luteinizing hormone. If there's too little of those, we have irregular or absent menses and infertility. Too much, we get early puberty, ovarian hyperstimulation. And then your thyroid stimulating hormone, too little of it, we get what's called central hypothyroidism, because again, this is coming from the anterior pituitary and not the thyroid itself. Central hypothyroidism. And if we have too much of the thyroid stimulating hormone, we get what's called central hyperthyroidism. Adrenocorticotrophic hormone, again, very similar. If we have too little of it, we get what's called secondary adrenal insufficiency, because again, this comes from the pituitary. And if we have too much, we get what's called Cushing's disease. Now, prolactin, too little, we're going to get decreased breast milk production, infertility, and irregular menses. Too much of it, we're going to get galactorrhea in both males and females, infertility, and gynecomastia in men. Now, thyroid can have two different situations where we have too much or too little of the thyroid stimulating hormone. And so hypothyroidism is where the thyroid does not produce enough of T3, T4. Some of these symptoms of hypothyroidism can be seen here in the diagram. A very severe form of this is what's called myxedema coma, and that is just a very exaggerated form of hypothyroidism. For hyperthyroidism, when we have too much, we get what's called Graves' disease. Hyperthyroidism symptoms are up here in this little diagram. But we get what's called Graves' disease, and that again is just kind of an exaggerated hyperthyroidism. Let's see here. And so another very severe form of hyperthyroidism is going to be called your thyroid crisis or a thyroid storm. And this is just kind of one of those situations where somebody has been running high in their thyroid hormones for a long time, kind of unchecked. Sometimes infection or surgery can cause this, but you get hyperthermia, kind of decreased alertness, abdominal pain, tachycardia, worsening symptoms. So those things can be very bad. And this down here is what's called a goiter. And that is just a enlargement and hyperplasia of your thyroid gland itself. And this can happen with both hypo and hyper. Your parathyroid glands, kind of similar. Those can have either too little or too much of the hormone floating around. Too little, you're going to get decreased calcium and decreased phosphorus. Too much parathyroid hormone, you can get an increased calcium, decreased phosphorus, and decreased magnesium. When you have hyperparathyroid, you can have either a primary or a secondary, which kind of helps us determine where it comes from. In the primary hyperthyroidism, hyperparathyroidism, you get increased parathyroid hormone and increased calcium in the bloodstream. But for secondary, your calcium is actually low. And so this can help diagnose where the problem is, whether it's with the parathyroid or with the pituitary or the hypothalamus. In the posterior pituitary gland, we have a couple of disorders there. If there is too much hormone coming from this area, if we have too much antidiuretic hormone, we get what's called symptom of inappropriate antidiuretic hormone. This is a condition that can cause a very low sodium, which can have neurological effects like seizures that you would want to be aware of. Sometimes there is a type of cancer called a small cell lung cancer that can actually cause an increase in this antidiuretic hormone. It's a tumor that actually produces that. And so sometimes it's not coming from the pituitary itself, it's actually coming from an ectopic or an outside source. Now, too little posterior pituitary glands, like too little antidiuretic hormone, can cause another condition called diabetes insipidus, which is where the body is trying hard to get rid of some of that extra water and try to flush the system. Now this can cause kind of a like concentrated sodium level in the bloodstream, and so you get a very high sodium level. This can be affecting the kidneys and the brain. It can have neurological effects as well, and so to be aware of those. In the adrenal glands, there are some conditions here that we want to be aware of. There's one called pheochromocytoma. This is a pretty rare tumor of the adrenal medulla that secretes too much epinephrine and norepinephrine. So as you can see, that might be pretty bad on the system. It can be life-threatening. It's hereditary and sporadic, and usually they get 10 to 15 minute episodes that sort of go away on its own, but they get the kind of, tachycardia, headache, diaphoresis, the stuff you would normally see with an increased epinephrine level. The other disorder of the adrenal glands is going to be adrenal insufficiency, and remember we talked about a secondary adrenal insufficiency before. This is actually the primary. This is a problem with the adrenals themselves, and this is called Addison's disease. And Addison's disease is kind of a deficiency in the adrenal cortex hormones, pretty low cortisol levels. It usually is an autoimmune destruction of the cortex. Sometimes you can get tumors or hemorrhage with this. There is also another condition that can result if this gets worse, called an adrenal crisis or an Addisonian crisis, and that's if the glucocorticoids that a person takes for the adrenal sufficiency, if those are stopped suddenly, it can cause severe hypotension, dehydration, fever, confusion. This can be a pretty sick person. The one time I did see this recently was a 4-year-old who came in looking like he had some kind of a virus, but we realized he has Addison's disease, and they ran out of his medication. And so he presented with fever and hypotension and confusion and altered mental status and things. So he was pretty sick. The other condition that we want to be aware of is Cushing's disease, and Cushing's syndrome rather. Cushing's syndrome is going to be excess cortisol, and that's caused by like too much glucocorticoids, or maybe there's an adenoma in the pituitary that is causing it to produce too much adrenocorticotropic hormone, and that can cause an increase in your cortisol level. Cushing's syndrome has some pretty significant effects on the body. Some of those you can see here in this diagram, such as the moon face and the buffalo hump. Those are all symptoms of too much cortisol. Now, the last condition that we're going to talk about is diabetes. Diabetes is kind of a big condition. There are a lot of people that have diabetes. Type 1, there is 2 different kinds. There is a 1A and a 1B. The 1A, your beta cells of your pancreas are destroyed by your immune system. The first couple years is called the honeymoon phase, where your cells are still producing insulin, but eventually you become deficient. Sometimes that first presents in what's called a DKA, or a diabetic ketoacidosis. And those are some that I'm sure, at least those of us in the ER and the ICU setting, are pretty familiar with at this point. Sometimes that is how type 1 diabetes first presents, is in somebody in a acute DKA. There is also something called LADA, or it's kind of a latent autoimmune diabetes of the adult. This is a pretty slower progression and a later onset of insulin deficiency, but it's still very similar. Type 1B is going to be hereditary. It's less common, and this one is kind of just an idiopathic destruction of the beta cells, whereas 1A is going to be autoimmune. 1B is more of a hereditary idiopathic. And some of the symptoms of diabetes type 1 is up here in this little diagram. Type 2 is a little different. As you can see here, interesting statistic, 1.2 million people 18 years or older diagnosed in 2021 for type 2. Accounts for 90 to 95% of all cases, which is pretty significant. It can occur in any age group. It often starts with insulin resistance, so the body doesn't use insulin properly. Causes the liver to produce more glucose, and it makes the blood sugar even higher. Eventually, your beta cells will fail. You'll have chronically high blood glucose and inflammatory markers from your adipose cells. That also will further worsen the cell destruction. So it's kind of a cascade of events. There are some risk factors for type 2 diabetes, and these are located down here. Hereditary, if somebody in your family also has diabetes, that can be a risk factor. Obesity is a known risk factor. Let's see here, and another one is metabolic syndrome. Metabolic syndrome is kind of a cluster of risk factors. It's diagnosed when you have 3 or more. This is going to be hyperglycemia, hypertension, hypercholesterolemia, or increased weight circumference. So those are all things that are risk factors for diabetes. One thing they can use, one blood test they can use to help gauge where you are in your control of your diabetes is called your A1C. This is going to be your average blood glucose over the past 2 to 3 months. And as you can see here, a normal range is less than or equal to 5.6. Pre-diabetes is 5.7 to 6.4. And then diabetes is classified as a 6.5 or higher A1C. A couple other types of diabetes. We have gestational diabetes. That is going to be diagnosed in your 2nd or 3rd trimester of pregnancy. One thing to note, 40 to 60% of women who have this will develop type 2 diabetes within 10 years. So it's very important to monitor diet and glucose levels during pregnancy as well. The last type of diabetes that we're going to talk about is monogenic diabetes. This one is kind of rare. It's transmitted in an autosomal dominant manner. It generally onset before the age of 25, and it's genetic. Those genetic abnormalities cause impaired glucose sensing and insulin secretion. Some patients require insulin, some just use like oral hypoglycemics, and some people can just manage this with diet and exercise. But that is kind of an interesting part of diabetes. There are some complications with diabetes to be aware of. These are going to be things like coronary artery disease, peripheral artery disease, cardiovascular disease, or cerebrovascular disease, rather. Hypertension. We talked about DKA, or diabetic ketoacidosis, and this is where you're going to find ketones in the urine, and this is produced because the body has exhausted all of its other resources. HHNKS is a syndrome that is very similar to DKA, except you don't get any ketones in the urine, but you still have high blood sugar and you still have some other symptoms that are very similar. The last thing to talk about is with having high blood sugar and having diabetes that's a complication is retinopathy. Diabetic retinopathy is the leading cause of blindness. So that is definitely something to be aware of. Neuropathy is a decreased sensation. That can happen a lot of times in hands and feet, but can also happen in a situation where a patient presents with chest pain. They may not have your classic pain response because of their decreased sensation and their lack of feeling in their chest. And so just to be aware, when somebody's diabetic, they might present just a little bit differently. Here are my references for all of this information that I've presented. Thank you so much for watching and for listening, and I do wish you the best of luck in your studies. Thank you.